This program is brought to you by Emory University.
Our first speaker today, we have two of our third years today doing Journal Club, and our first speaker today will be Billy Joe Mullinax, who is a South Carolina native who comes to us from Medical University of South Carolina, then did his residency at Emory and has stayed on as a general cardiology fellow, and will be doing interventional cardiology fellowship next year. Following him will be Rachel Tobin, who is also a third-year fellow. She was a Duke medical school graduate, went to Duke residency, and then we were lucky enough to get her here at Emory, and she will be doing heart failure fellowship. I will let Billy Joe introduce his topic.
Good morning, everyone. Thank you, Dr. Coley. As you see this morning, we're going to talk about the drug-coated balloon BIF trial, which is looking at drug-coated balloon versus NC balloon and side branch stenting of bifurcation lesions, specifically true bifurcations. This came out a few months ago. I have no disclosures. We're going to talk just a little bit about the growing utility of drug-coated balloon, and I'm going to touch on why bifurcation stenting is complex and why we try to plan these procedures, and then we're going to appraise this article and compare it to a case. So starting off with this gentleman here, we met I guess about a month and a half ago now. He was 75, he had hypertension and diabetes, and he came to the hospital with chest pain, a few other things that I'll talk about in a second, as well as found to have a non-STEMI. He had no symptoms of heart failure. His troponin, traditional troponin, peaked at 1.2. He did have diabetes mildly with an A1C of 6.9. His LDL was controlled. And here's our EKG. As you see, there's some inferior cues on there, but other than a right bundle, there's no really acute ST or T changes. We do have a surface echo. I'll let everyone take a second look at that. And we have our angiogram. I'll let it play a few times, and then I'll show you the right. Okay, what everyone's probably noticed is that the patient's got disease in the RCA, and the patient has a proximal LAD lesion. The RCA has a severe lesion in the mid, as well as that distal subtotal, and then the LAD had a severe lesion. The circumflex was just moderate, and then the ejection fraction was read as in the mid-range. Syn test score was 26. The patient had resolved symptoms at this time, and so we stopped and we requested a CABG evaluation, and we were going to have a heart team discussion. There were some plot twists going on, though. This patient actually was having an acute mental health crisis at the time, and he was refractory to medical therapy and had been followed with psychiatry beforehand, and he had previously required ECT. And that was the only thing that actually helped this patient, and they wanted to do it again. However, with his initial presentation and this coronary anatomy anesthesia was pretty reluctant to offer him any anesthesia to do the ECT. So there was a lot of back and forth about what should be done first. This was of particular concern because the patient did not want to take medications, wasn't taking any medications beforehand. So there was a lot of coaching and talking involved before he would do any medications every single day for every single dose. Okay, so why should we care about bifurcation disease? And I'll say it's more complex. There's worry about losing your side branch, and we're going to talk about a little bit of which side branches we should think about specifically in this paper. So the cases can be a little longer. It really depends on, I guess, your strategy. Also, how much pretreatment, if any, the patient's going to require. It also comes with higher complication rates compared to more straightforward lesions, whether that be TLR or target lesion failure. And then there can be rates of ISR, which again I'll talk about. A couple of different strategies. we've kind of shifted now into a provisional strategy first, followed by proximal optimization technique, plus or minus if you need a kissing balloon. And then we have direct 2-stent strategies. And then depending on the anatomy type, we may choose whether that be anywhere from a T all the way down to a DK crush, depending on the angle, and then bailout culottes. Now, again, higher rates of complications with respect to success, and then follow up. There tends to be, if there's going to be ISR, it tends to be at the ostium of the side branch. We do have strategies that have helped, but things are still, like I said, more complicated. So strategies like POT or the proximal optimization technique, kissing balloon inflations, and then minimal stent overlap areas are ways to optimize these results. But depending on the angle, that can be challenging. I think if we're going to improve our rates of CABG turndown patients, and we have so many patients who are now CABG turndowns, we really should try to have the best technique that we can. And then perhaps, like this study suggests, for appropriate side branches, leaving nothing behind may be the way to do it. Okay, as I'm sure all of you know, DCBs were available in Europe long before we had them for coronary use. We were using them for peripheral cases. Now we're using them for in-stent restenosis after the agent trial. So we have a paclitaxel coated balloon, and then just for procedural knowledge, for the coronary inflations, it tends to be, by the company, recommended 30 seconds to a minute as compared to, say, up to 2 minutes in peripheral cases, but we do longer coronary inflations if the patient can tolerate them. Prior trial looked at a similar question as this study, which was drug-coated balloon versus NC balloon in the side branch. This was non-left main. The endpoints were a little odd. They looked at angiographic stenosis at 9 points, 9 months, and then the clinical outcomes were all secondary outpoints. And despite there being anatomic improvement at 9 months, there was no clinical outcomes, but again, they were all secondary. It was limited, it was unblinded. They did not include left mains, and the reference vessel lumen minimal diameter was 1.2, so it's kind of small. Okay, so let's jump into our trial. This was a multi-center international trial. I would say these are pretty experienced operators. All of them had greater than 100 bifurcation PCIs annually. Obviously, you cannot blind the operator, the cath lab staff. If you have not seen a drug-coated balloon, they look different than a regular NC balloon. You also have to treat them a little differently when they go through the co-pilot. So you have to know. However, the patients and all the personnel treating the patient afterwards were blinded, and then the person who, when we did computerized system for putting the patient in which side of the study, so when they were randomized. But as far as the patient himself, they underwent provisional main vessel stenting with a limus eluting stent with a jailed side branch technique, which I'll show in a picture in just a moment, followed by POT. And then after this point, we reevaluated, and then eligible patients went through with either stenting with a non-compliant balloon or a drug-coated balloon. And they did 2 minutes. They had to deliver the drug-coated balloon within 2 minutes of it entering the catheter system, and then inflated nominally for 60 seconds or 2 30-second inflations if it was poorly tolerated. But they wanted 60 seconds total of inflation time. They were eligible if they had greater than 70% ostial side branch stenosis, and they had a true bifurcation. So their strategy was wire both vessels, pre-dilate the main vessel, stent the main vessel, and then do the POT technique we talked about, and then they checked the result, left the wire in place. And as mentioned, if needed, did additional steps. So they rewired the side branch, removed the jailed wire, and then at this point, depending on which way they went down, it may differ a bit. If it was going to stay NC balloon, it'd be similar here. You may have pre-treatment, and then the kissing balloon, and then POT, final result picture. If they were going to do DCB, this is where things differ. So they get pre-treatment, then they get, and that would be with a non-compliant balloon, and then they get the drug-coated balloon delivered. Then they would get a kissing balloon inflation again, then POT, then final result. So the extra step is there. These patients were all adults. They had one of a few presentations, and this is important. So they were 18, obviously silent ischemia, stable or unstable angina, AMI greater than a week of onset of the angina. Simple or true bifurcations, which we'll talk about with those 3 Medina classifications. The main vessel and side branch both had to be, at least reasonably sized vessel. In this case, was greater than 2.5 millimeters and have greater than 50% stenosis. Side branch lesion length had to be less than 10 millimeters. Ostial side branch stenosis greater than 70% after main vessel stenting. And then there had to be, any CTO had to be recanalized before enrollment. I just want to bring this up because these criteria would also be something where we would decide to do anything about the side branch before we even started a bifurcation lesion. So if there was a short segment of disease without severe stenosis with good flow in the side branch, you're probably going to end up doing a provisional strategy anyway. And so it's not like you're going to go in with a 2-stamp strategy in these kind of cases. These patients were excluded if they had any reason to not get the drug or if they had any intolerance to DAPT. They were going to die within 12 months, hemodynamically unstable, any ISR or severely calcified lesion requiring specifically rotational atherectomy is what they list, and then pregnant or breastfeeding patients. Like I said earlier, they screening eligibility, they then went under the web-based randomization. Okay, this is the Medina classification. This is what we use to classify bifurcation lesions. And these are the 3 that they included, the true bifurcations. So if you remember back to our angiogram, our actual patient was sitting here. So beforehand, we had a 110. The only thing that was also notable on that diagonal side branch was that there was actually some aneurysmal changes to that vessel, so we can come back and think about this a little bit later. But these are our 3 included classifications. This would be after main vessel stenting. So disease in the proximal segment of the main vessel, distal segment of the main vessel, and then in the ostium of the side branch, or in this case, proximal main vessel, side branch, or the distal main vessel and the side branch. Okay, these patients had a fair bit of follow-up. I mean, obviously you had your index procedure, and then basically a 3 and 6 month visit, a 12-month visit, and then at 13 months, everybody had the option of undergoing a repeat angiogram. There's a 24-month visit and a 36-month visit. Our endpoints were predominantly MACE. So the primary endpoint was a composite of cardiac death, clinically driven target lesion revascularization, or target vessel MI. And that could either be spontaneous or peri-procedural. Safety endpoint was definite or probable stent thrombosis. Our secondary endpoints included all-cause death, MACE without peri-procedural MI, and then the 2 types of the MI that we talked about, target vessel MI, and then TLR, or clinically driven TLR, clinically and procedural success, and anything if you have to do a crossover. Here are the patients who were ultimately enrolled. I will tell you that there was no significant difference in the baseline characteristics of these patients, predominantly in their 60s and predominantly male. Looks like most of the folks were presentations of unstable angina, and then obviously our other comorbidities. Again, no significant difference. We are going to sit here just for a moment. So of the lesion and procedural characteristics, there's no significant difference between these. However, if you look at the procedural techniques, there were a couple things that caught my eye. I thought it was kind of interesting that not everyone had repot after the first casing balloon inflation. That's not actually marked on here, but I thought that was kind of a surprise to me, and that at least in my learning so far, pot is quite important, and we try to make sure we optimize that proximal segment after any time we do any treatment distally. Also, IVUS was only used, or IVUS or OCT was only used in about 25 or 30% of cases in this. Again, we're really moving into an era where we're using a lot more IVUS. So I find that it's a new class 1 recommendation. Now, clearly this became before this, but I just find that interesting. It's not that much imaging done. And then up here, I will make it clear there was some crossover of patients in the non-compliant balloon who did get a drug-coated balloon. Again, it was 4. And I won't skip to the punchline, but they did their statistics a couple different ways, including these people per protocol, as well as how they were randomized and that there was no difference in what they found. Primary outcomes were that the drug-coated balloon compared to the non-compliant balloon had improvement in MACE that was predominantly driven by target vessel MI, but there was no significant difference in paraprocedural MI. So this is our cumulative event rate. This is the paraprocedural MI with no statistical difference is 0.09. And then this is the target vessel MI, so 0.008. So here are endpoints, improvement in MACE, but there are a couple other things to talk about. Safety endpoints, they said there was no statistical difference in any safety endpoint. But there's more cases of all-cause death as well as stent thrombosis in the drug-coated balloon group. Again, they say it was, the statistics suggest that they were not significant, but there was more events in that drug-coated balloon group. And as we talked before, more MACE events in the non-compliant group. Okay. So I wanted to kind of recap here. So multi-center randomized trial between DCB and non-compliant balloon for true bifurcation stents in the side branch found that there was an improvement in MACE for the drug-coated balloon, mostly driven by spontaneous target vessel MI, which is greater than 40 hours from the procedure, not paraprocedural MI. A couple thoughts I had, it's statistically safe, improved MACE with better procedural success. It sounds reasonable to me. I will say that I have been pretty interested in DCB for a while, so I do have that small bias. The things that were unsettling to me was that there was more stent thrombosis and death, even if it wasn't statistically significant. So I would say, based on this study, it's a reasonable strategy to consider, but if it's going to create undue burden, whether that be to the patient or the system, I don't know that I would do it. Case closure. So coming back to our guy, he actually would have screen failed. So he would not have been included. His AMI was within 7 days. Side branch after stenting, which I did not show you, but he did not have 70% stenosis after angioplasty and 50% pre-treatment. I also don't know what they would have done with that aneurysmal segment at that ostial diag. And then he was quite calcified, but he got shockwave IVL and did not get rotational atherectomy. So I'm not exactly sure how they would have done that. I think they would have not had an issue with that, but it was calcified. And he ultimately went to back to consideration VCT, but they still didn't give it to him, and then he had a poor outcome, unfortunately, related to his depression. So with that, I will take any questions, and thank you for your attention.
All right, if we don't have any questions or comments for Billy Joe, then we will move on to Rachel's presentation. And if anything comes up for Billy Joe later, we can readdress at the end of Rachel's presentation as well. Rachel, take it away.
All right, good morning, everyone. Thank you for joining. Let me go ahead and share my screen here.
I'm sorry, Rachel, while you're doing that, Billy Joe, there's a comment in the chat box that I just saw. I don't know if you can see it there, but it says reason for decreased imaging use is that a lot of the countries, for example, Indonesia, the patient has to pay for IVUS. And then he asked the question, will the deaths rekindle the paclitaxel fears?
I think maybe it's certainly something to think about. And when I was getting some feedback on this talk, Dr. Sosdave and I talked about how these stents and the drug-coated balloons did have different medication and what concerns that may bring up. So maybe that'll make some of the excitement on the sirolimus drug-coated balloon trial that is being done now more exciting. And I'm sure that folks would be more apt to reach for a balloon with the same medication if they're going to be doing any kind of combination therapy. But it's certainly worth thinking about.
Great, thanks, Billy Joe. And now we've got Rachel.
Good morning. So I'm going to be presenting the PEERLESS trial this morning. So this trial is entitled Large Bore Mechanical Thrombectomy versus Catheter-Directed Thrombolysis and the Management of Intermediate Risk PE, Primary Results of the PEERLESS Randomized Controlled Trial. And you can see here, Emory's own Wissam Jaber is the first author of this paper. It was initially presented at TCT, and it was just published about a little over a month ago in Circulation. So starting with some background, PE is the third leading cause of cardiovascular death behind heart attack and stroke. The incidence of PE in the US is about 1.15 patients per 1,000 patients, with up to 100,000 PE deaths in the US each year. From 2010 to 2018, the proportion of patients presenting to the ED with PE doubled, and risk factors associated with increased early mortality included hemodynamic instability, RV dysfunction on either echo or CT, or elevated cardiac biomarkers such as troponin. You may have heard of high, intermediate, low risk PE, and this stratification system comes from the ESC guidelines. So high risk patients are those with hemodynamic instability with high clinical parameter scores such as the PE Severity Index or PESI, or Simplified PE Severity Index, and they do have evidence of RV dysfunction or elevated biomarkers as well. In contrast, low risk patients are hemodynamically stable with low PESI or S-PESI scores with no RV dysfunction and no elevation in troponin. The intermediate risk group, which is what we're going to focus on for the PEERLESS trial, there's high risk and low risk patients. All these patients are hemodynamically stable, all have elevated PESI or S-PESI scores. The intermediate high risk patients have both RV dysfunction and or elevated troponin, and then intermediate low risk have one or none of the RV dysfunction or elevated troponin. Just a refresher, PESI score is a way to classify patients as either high or low risk clinically, with age greater than 80, history of cancer, chronic cardiopulmonary disease, systolic blood pressure less than 100, or heart rate greater than equal to 110, or O2 sat less than 90 taken into account. And a score greater than or equal to 1 puts them into that category of more concerning risk. Another classification system that you may have heard mentioned is this massive, submassive, low-risk PE. And this comes from the American Heart Association guidelines. And these are older guidelines from 2011. And massive patients are the hemodynamically unstable patients. Low-risk patients are the hemodynamically stable with low PESI or S-PESI scores and no evidence of RV dysfunction. And then submassive, similar to the intermediate risk patients, they're hemodynamically stable, but they have higher PESI or S-PESI scores, and they may have abnormal RV imaging, elevated troponin, or both. Currently, looking at the ESC guidelines, and this is from 2019, high-risk patients are recommended to get systemic lytics. Low-risk patients, in contrast, should get anticoagulation. This intermediate group patients, the guidelines currently at this time recommend anticoagulation. However, we know that early mortality is high in this intermediate risk group, with mortality ranging from 3 to 15% and clinical deterioration ranging from 5 to 18%. Therefore, alternative therapies are definitely needed. And the PEERLESS trial looks at 2 interventional therapies, including large bore mechanical thrombectomy, which you'll see abbreviated in the rest of this talk as LBMT, or catheter-directed lytics, which you'll see as CDT. The mechanical thrombectomy that was used in this trial was the FlowTriever system by Emory Medical, and this is used either a 16 French, 20 French, or 24 Triever aspiration catheter done by femoral access. And catheter-directed lytics is a way to deliver the lytics directly in the vessel using a catheter. The ECOS catheter is the most commonly used in this trial, and that delivers lytics with also ultrasound, and the ultrasound waves help to break up fibrin components. So just quickly touching on some previous intermediate risk PE trials. About a decade ago, the PYTHO trial was one of the bigger trials looking at treatment for intermediate risk PE. And they looked at systemic lytics plus heparin compared to just anticoagulation alone. And they did find a significant decrease in hemodynamic decompensation or death, 2.6% with systemic lytics compared to 5.6% with anticoagulation alone. However, this came at the increased risk of major bleeding and stroke. And then there were two prospective trials to touch on. Seattle 2 was a prospective trial of catheter-directed lytics. They did find decreased RV dilation, pulmonary hypertension, thrombus burden, and it was a safe procedure with minimized intracranial hemorrhage. And then FLASH, which was from 2023, is another prospective trial looking at mechanical thrombectomy. And this again had favorable safety profile with improvements in hemodynamic, PA pressures, functional outcomes, and there was low 30-day mortality overall at 0.8%. There are a few retrospective comparison studies out there of mechanical thrombectomy versus catheter-directed lytics. One I'll point out is from Errol Ince, one of our former fellows here at Emory. Both of them did not show a difference between mechanical thrombectomy and catheter-directed lytics in terms of clinical outcomes and safety endpoints. So the PEERLESS trial, this was the first randomized controlled trial to compare interventional strategies such as mechanical thrombectomy and catheter-directed lytics for intermediate risk PE. And the aim here was to determine whether mechanical thrombectomy reduced the incidence of in-hospital adverse clinical outcomes compared with catheter-directed lytics by providing more rapid removal of emboli and relief of RV dysfunction. Patients were included if they were greater than 18 years old. They did have to have an intermediate risk PE by the ESC guidelines with evidence of RV dysfunction on either CT, PE, or echo. They had to have a proximal filling defect, and it had to be acute, so symptom duration less than 14 days, and intervention had to be planned within 72 hours of diagnosis or transfer to the hospital. And they had to have one additional risk factor, and that had to be either elevated troponin, heart failure, lung disease, elevated heart rate, low blood pressure, elevated respiratory rate or hypoxia, syncope related to PE, or elevated lactate. Patients could not be included in this trial if they could not be anticoagulated, if they had a right heart clot in transit, if life expectancy was less than 30 days, or if their intra-procedural systolic pulmonary artery pressures were greater than or equal to 70. And the reason for that is they wanted to include patients with acute PE who would benefit from catheter-directed lytics and didn't want to have more of a chronic PE picture included. And then patients with CTEPH were also excluded from this trial. So they looked at 57 sites across the US and Europe. Patients were randomized 1-to-1, and they were stratified by bleeding risk. So either high bleeding risk with VTE bleed scores greater than or equal to 2, or low risk less than 2. Patients were followed at 24 hours, hospital discharge, and 30 days, and follow-up imaging was performed at the 24-hour visit, and they used whatever modality patients had at baseline, whether that was echo or CT. It was an intention to treat analysis. As mentioned in this trial for mechanical thrombectomy, they used the Inari FlowTriever system. Of note for catheter-directed lytics, so there was no standardized protocol for what the different sites should use. It was based on their own protocols. The majority of catheter-directed lytics in this trial were the EGOS catheter, which is that ultrasound-facilitated catheter-directed lytics, but there were other types of catheter-directed lytic systems used in the trial. And then their endpoint is interesting. So their primary endpoint was this hierarchical win ratio composite that they looked at either at discharge or 7 days after procedure. It took in several components, including all-cause mortality, intracranial hemorrhage, major bleeding, clinical deterioration and or escalation to bailout therapy, and post-procedural ICU admission and length of time in ICU. The idea of this win ratio was given the investigators the ability to rank the items in the composite in terms of clinical importance. So the way it worked is each patient treated with mechanical thrombectomy compared to each patient with catheter-directed lytics, and starting at the top, so looked at all-cause mortality. They decided, was there a winner between mechanical thrombectomy or catheter-directed lytics? If it was a tie, then they would move down to intracranial hemorrhage and then down to major bleeding, et cetera. As soon as there was a winner decided, then it was terminated there. And then the win ratio was calculated by dividing the number of mechanical thrombectomy winners by the number of catheter-directed lytic winners. They looked at a lot of secondary endpoints in the trial. So they looked at the first 4 components of that win ratio, excluding the ICU admission. They also looked at each component of the primary endpoint individually, the change in RV to LV ratio from baseline to 24 hours, dyspnea and NYHA classification scores at both 24 hours and 30 days, quality of life scores, device and drug-related adverse events, PE-related readmissions and all-cause readmission, all-cause 30-day mortality, and total and post-procedural hospital stay, an ICU stay. So they randomized initially 599 patients. They did have to exclude, it looks like about 6% in each arm for systolic PA pressures greater than or equal to 70 prior to treatment. And they enrolled 274 patients in the mechanical thrombectomy arm and 276 in the catheter-directed lytics arm. At 24 hours, they had 100% of patients in the mechanical thrombectomy arm alive, and same with in the catheter-directed lytics. The primary endpoint, again, this was done at either discharge or 7 days. There was one patient who was deceased in the catheter-directed lytics arm, and all patients still alive in the mechanical thrombectomy arm. And then at 30 days, they had great follow-up, and there was only 1 death in the mechanical thrombectomy arm and 2 deaths in the catheter-directed lytics arm. Looking at baseline characteristics, the average age for this patient population was in the early 60s, and a little over half of the patients were male. It was a predominantly white patient population, and a good amount, about 60 to 65%, did have DVT as well. One thing to point out here, which I did highlight in red, is they had a relatively low patient population who had relative contraindications to thrombolytics. In some other PE registries, this number could be up to 30%. Here, they had about 4% in this trial. For VTE bleed scores, they also had a lower than expected high-risk bleeding population, with only about 25% of patients having a VTE bleed score greater than or equal to 2. Initially, they were aiming for actually greater than 35%. SPESI scores, about 3/4 of patients had a score greater than or equal to 1, and almost all patients had elevated troponin levels. You can see here, almost 40% of patients had saddle PE. These patients were tachycardic, but they were normotensive. And this dyspnea score, this MMRC, a score of 0 means that you only are dyspneic with strenuous exercise, whereas a score of 4 is getting so dyspneic that you can't leave the house or get dyspneic just dressing. And upwards in one group about 40% and then 46% in the catheter-directed lytics group were so dyspneic here that they weren't able to leave the house or dress without getting dyspneic. The majority of patients were NYHA class 3. The RV to LV ratio was close to 1.3 at baseline, and majority of patients had severely reduced RV function. Almost all these patients were anticoagulated, and the mean PA pressures were around 30, and all the baseline characteristics are pretty similar between both groups. So looking at some of the procedural characteristics, mechanical thrombectomy was a longer procedure with more fluoroscopy time. And catheter-directed lytics, obviously, since the catheters are indwelling, had longer indwelling catheter time. For mechanical thrombectomy, almost all of the cases were done using femoral access, whereas catheter-directed lytics, 35% were done using jugular venous access. Mechanical thrombectomy did have more blood loss. It did have more reduction in mean PA pressures, with an average of 5.9 compared to 3.6 with catheter-directed lytics. And then, as mentioned, in terms of catheter-directed lytics, there was not a standardized protocol, so it was up to the institution. 59.8% of the cases were ECOS catheter, which is that ultrasound-facilitated catheter-directed lytic. 92% used bilateral catheters, almost all TPA, with an average rate of 0.5 to 1 milligrams per hour. And the infusion time, the most common, was 6 to 12 hours. So jumping into results, this is looking at that primary win ratio. And this, again, took into component all-cause mortality, intracranial hemorrhage, major bleeding, clinical deterioration and or escalation to needing bailout therapy, and post-procedural ICU admission. And again, it went in a hierarchical order, first looking at mortality, then intracranial hemorrhage, et cetera. And you can see here, it did significantly favor mechanical thrombectomy over catheter-directed lytics, with a win ratio of 5.01. However, once you took out ICU stay and you just look at the first 4 components, that win ratio was not statistically significant. There also was not a statistically significant difference between all-cause mortality, intracranial hemorrhage, or major bleeding. There was a significant difference in clinical deterioration or escalation to bailout therapy, which favored mechanical thrombectomy, and then post-procedural ICU admission favored mechanical thrombectomy. And we'll talk more about this, but this is somewhat intuitive, as almost all patients with catheter-directed lytics was the institutional protocol to put them in the ICU for monitoring. In terms of clinical deterioration, so I do think this is important to mention that it did favor mechanical thrombectomy over catheter-directed lytics. So only 1.8% of patients with mechanical thrombectomy had clinical deterioration and or need for bailout therapy, compared to 5.4% in catheter-directed lytics arm. And this was statistically significant. You can see here the reasons for clinical deterioration were, you could argue, less severe in mechanical thrombectomy, with no instances of cardiac arrest, no instance of high degree AV block, and no instance of respiratory failure. And in the mechanical thrombectomy arm, all deteriorations occurred actually in the interventional suite on the index day of the procedure and were resolved same day. Whereas for catheter-directed lytics, on average, deterioration occurred about 2.1 overnights later. 5 patients in the catheter-directed lytics arm did undergo bailout with mechanical thrombectomy. And in each arm, one in the mechanical thrombectomy arm and one in the catheter-directed lytics arm, they had multiple unsuccessful attempts and died after 7 days. At 24 hours, the bottom line is everything that they looked at was statistically significant in favor of mechanical thrombectomy, except for a reduction in RV and LV ratio. So these patients had lower dyspnea scores, lower respiratory rates, lower NYHA classification. And interestingly, RV function was better on echo in terms of mechanical thrombectomy, but there was not that reduction in RV to LV ratio. Looking at ICU use and hospital stay, again, this was argued, somewhat intuitive, as all but 1.4% of patients in the catheter-directed lytics arm did have to go to the ICU. In mechanical thrombectomy, 58.4% did not need ICU admission. And then you can see here, patients in mechanical thrombectomy who did have to go to the ICU were there for shorter amounts of time. And this led to a total hospital stay and post-procedural hospital stay time almost a day less for mechanical thrombectomy arm compared to catheter-directed lytics. At 30 days, there was not a statistically significant difference in dyspnea scores, NYHA classification scores, quality of life scores, or drug or device-related adverse events. There also was not a difference in all-cause mortality. And I will point out all-cause mortality was very low in this trial overall, which is pretty awesome. So in the mechanical thrombectomy arm, there was only 0.4% all-cause mortality. In catheter-directed lytics arm, only 0.8%. You can see here I have highlighted all-cause readmission was statistically significant in favor of mechanical thrombectomy. However, PE-related readmission, there was not a statistical significant difference. So to discuss this trial, this was the first RCT to evaluate interventional strategies in the intermediate risk PE population. And it did favor mechanical thrombectomy with that win ratio of 5.01. However, there was not a significant difference in in-hospital mortality, intracranial hemorrhage, or major bleeding. The result did stem a lot from the fact that there were lower rates of ICU admission and clinical deterioration and escalation to bailout therapy. As mentioned, pretty amazing that there were low mortality rates overall for this intermediate PE risk group. And when you put this in context to PITO about a decade ago, so in this trial, we don't have the comparison to anticoagulation alone. But in PITO, when they looked at lytics compared to anticoagulation, in anticoagulation arm alone, the mortality rate was 3.2%. So overall, in both intervention arms, much lower mortality rate than historical data. Clinical deterioration was also favored in terms of mechanical thrombectomy. And it was thought that perhaps patients with mechanical thrombectomy had lower rates of clinical deterioration and need for bailout therapy because of better RV function at 24 hours. The timing of clinical deterioration is also important to note, whereas in mechanical thrombectomy, all of these deteriorations occurred on the index day of procedure, whereas in the catheter-directed lytics arm, it was approximately 2.1 overnights later. And you can argue in mechanical thrombectomy, there were less severe instances of deterioration when they did occur, with no instances of cardiac arrest, high-grade AV block, or respiratory failure. And then only about 1% of the total cohort needed this bailout therapy. So again, this is a win for these catheter-based interventions overall. The lower ICU stay with mechanical thrombectomy, I do think it's important to talk about this. This is an intuitive outcome, as most hospital protocols did require ICU monitoring for patients with catheter-directed lytics. And the authors state, we acknowledge that ICU use outcomes may therefore be less impactful for informing clinical practice than other secondary endpoints. However, putting this into clinical context, it's still an important metric because time in the ICU leads to higher costs for patients and is a strain on the system in terms of the ICU bed shortage. Limitations of the study. So this patient population was a lower bleeding risk patient population than the average PE, intermediate risk PE population. As mentioned, their contraindications to thrombolytics was only 4.2%. And in some PE registries, this can be up to 30%. And they also had lower proportion of patients with high VT bleed scores. They were initially aiming for upwards of 35%, and they got 26.4%. Leading to the question, can we generalize these results to the broader PE patient population, especially in terms of intracranial hemorrhage and major bleeding? It was an open label trial. Obviously, participants and investigators could not be blinded. The decision to escalate care was left to the operator. And then the treatment arm, as mentioned, for catheter-directed lytics was not standardized, but the majority of patients did undergo ultrasound-facilitated catheter-directed lytics using the ECOS catheter. No long-term data over 30 days, not necessarily limitation, but important to mention, it was an industry-sponsored trial by Emory Medical. And then the inclusion of ICU stay in the outcome did bias results in favor of mechanical thrombectomy, which we've already touched on. So future directions, it's going to be important to know how mechanical thrombectomy and catheter-directed lytics compare when looking at anticoagulation alone. And there's 3 ongoing trials at this time. PEERLESS 2 is going to look at mechanical thrombectomy compared to anticoagulation. HI-PYTHO is going to look at catheter-directed lytics and anticoagulation. And PE-TRACT is another trial looking at catheter-directed lytics and anticoagulation. And hopefully we should have the results and some more information soon. So in conclusion, there was a statistically significant difference in the win ratio in favor of mechanical thrombectomy compared to catheter-directed lytics for a patient with acute intermediate risk PE. Mechanical thrombectomy was associated with fewer clinical deteriorations and need for bailout therapy, less post-procedural ICU time, shorter hospital length of stay, fewer readmissions, and mortality rates and bleeding were similar for mechanical thrombectomy and catheter-directed lytics. So that's all I have. I do want to thank Dr. Jabber, who I saw earlier was on this call. He took some time to speak with me about this trial, and I'm happy to open this up to any questions.
Thanks, Rachel. That was a great presentation. Dr. Jabber did have a comment in the chat. He mentions that win ratio is also helpful in combining binary with non-binary outcomes like death and length of stay. It has been used in the partner and tier trials as well. And he mentions a great presentation.
Thank you.
Hey, Rachel.
Hi, Dr. Clements.
How you doing?
Great. How are you?
That was good. This reminds me of a lot of other trials we've had and something that intuitively makes sense, but you simply have to get over the learning curve and prove that it really works. So, so I'm a believer in that it really works, and I think it's great that we have this technique. Unfortunately, a lot of times when we see something we can suck out, there are also many times underlying obstructions in smaller vessels that we can't suck out. That leaves us in the CTEP kind of category, like one we've had recently that maybe you saw with something floating around the right atrium, but the right ventricle was jammed up. The McCollum sign was there. The right ventricle was as larger than the left. And it simply makes sense to get what you can out, and then you have to know that there's a lot more down in the pulmonary circulation. So so I enjoyed that very much, and so glad we have this technique. Thanks to Wissam Jabber for all the good work he's done with that, and Mike McDaniel. I think that's advanced our treatment of this modality. One thing about the terminology here, the term strain is all confused, in my opinion. Like the radiologist on a CT scan, if the right ventricle is as large as the left, then they'll say the strain. Because when you say strain to the echocardiography group, you know, they're thinking about Langranian longitudinal strain, and either the free wall, the right ventricle, the free wall plus the septal wall, and whether or not it's less than 24 in the right ventricle. So that's very confusing. But if you read about the radiology definition, if the right ventricle is larger than the left, they call that RV strain. So thanks for a great presentation.
Thanks, Dr. Clements.
Great point, Dr. Clements. I don't know if you guys hear me. I'm out of the country. Wissam here. Great work, both of you guys. So these comments are important, and actually maybe we should move away from using the word strain in our PE literature to answer the question about, or the kind of talk about the comment about longer term and chronic PE. I mean, this is a separate question, and we have enough data now maybe to point us towards the direction that if we do something early on these patients that are sicker than the average PE patients, we are maybe saving lives or helping them early on get out of trouble quicker. And there's some more data, like Rachel mentioned, to see if that's really true with larger trials ongoing now. We should see the answers in the next year or two. But there's another big question about if we are aggressive with these patients early on, do we reduce the chance of CTEPH down the road? And the question is not answered yet. One of the trials that Rachel mentioned called PE Track, we're also part of it. We're looking at that specific question about what would the outcome be in the cardiopulmonary stress test at 3 months if we're aggressive with these patients with any intervention early on versus just anticoagulation. But these are all important things, and we're learning a lot in the PE world, and this is just the beginning of more data to come.
If I could just chime in, I totally agree with all the comments that have been made, and just want to echo what a big deal it is for Wissam to lead this. This is really an incredible trial, so important for the PE space, and what a win for Emory to have Wissam at the lead leading this. I think the second point to this trial is that it's also a win for 2 different techniques. Certainly catheter embolectomy has a couple edges, but it also shows that catheter lytics is pretty safe. And when you look at worldwide what people might be able to do easier, catheter lytics is still an easier procedure than catheter embolectomy. The third thing is, I think that what we really need to do also in the catheter-lysis space is to understand, do you really need to put a catheter in, or can you just drip in small amounts of TPA? Because if you think about what worldwide could do for patients, maybe the easiest thing is to do no catheter therapy with a little bit of tiny lytics to do that, and that might be just as good as dripping in TPA through a catheter. We still have to learn a lot about where is the benefit in catheter lysis. Is it in the lysis, or is it in the catheter, or is it in both? So there's still a lot to learn there. And lastly, I think what we've all agreed upon is that the embolectomy procedures are probably way superior in the proximal large main vessels, but lytics is probably better in the distal smaller vessels. And so ultimately, probably the best treatment is going to be some form of combination of the two. And so we're going to learn a lot from these procedures, but probably some mixing of both of these techniques, whether it's some systemic lytics dripped in slowly either before or after the catheters, and embolectomy is going to probably be the winner. So I look at this as a win for both techniques, and that it's a lot safer than what we used to do with systemic lytics. So great job.
Yeah, this is Neil Dickert. So I would echo everything everyone else has said as well, and really appreciate Wissam's leadership of the study, and really Emory's involvement in, as Wissam mentioned, multiple of these trials, which I think are I think I agree, best thought of as a sort of series of kind of a package deal that's going to help us get a lot of clarity over time. And clearly we're already getting important insights. The one thing I would mention, and I think is really interesting, is this notion of kind of the way we create primary outcomes and the way we think of these things. And the win ratio, as Rachel, I think, first of all, really nice, clear explanation of how that was derived and the motivations for doing it, right? Because we have different kinds of components of composite outcomes, and they're not all the same. Cardiology has a long history of trials that have been stopped early because of less important components of primary outcomes, and has really led us to not know sometimes whether there's a difference in the things that we care about most. The one caution I would have, and I don't know if Wissam has comments or Rachel, you have comments. I mean, the interesting thing about this study is, obviously the overwhelming push is ICU stay, which, as you point out, is not only is expected / required in the context of most catheter-directed lysis. There's a sense in which you want to say, well, there's no cost to it because it was done. You only get to that point after you haven't won in any other comparison. There is a cost, though, in the sense that the trial is going to be powered for an outcome that is looking at for the primary outcome, right? And if you include that in the primary outcome, you have an expected difference, and so what you end up with is a smaller trial than what a lot of us might like to see to really demonstrate whether there's a big difference in the first 4 components. So I do think it's important to at least acknowledge that while it has significant advantages of a traditional composite outcome that doesn't distinguish between components, there is a bit of a cost in terms of trial size and what impact we're able to detect on what we think are the more important, kind of what I would call more proximal major components. So it's just and I don't know if Wissam has thoughts on this, but
yeah,
it's interesting as to whether you could have treated it as a pre-specified secondary outcome or something like that, rather than putting it into the primary outcome, and it would have resulted in a different size trial.
Yeah, Neil, that's such an important comment. In fact, if we just went with the first 4 outcomes as our win ratio, the headline in the journal would be a negative study on PE intervention of catheter-directed lytics versus thrombectomy, right? Because that was not statistically positive. And sometimes you add these and just to kind of like get some wins when it comes to these trials, to have a positive trial. And it was a chance that we found significant difference in the other outcomes. But the sponsors of the studies always kind of like look at ways to make things more exciting for them. So it's kind of like a tug when you're designing these trials between the sponsors that want to give you money for the trial versus what can be achieved and what we can get out. And I think eventually it's a win to see what happened and to look at the data and to understand within a well-done trial what the outcome is and what ICU stay is in both arms and length of stay. All these are important, and readmission. I mean, there's a lot of other things that tie to that were important, that were not known before and now are known. So it is an important outcome, though. Yes, it pushes the whole outcome in one direction.
I would just add one other sort of minor comment, which is that I know, because I was looking at it while you were presenting, Rachel, Wissam and others from Emory had published a paper looking at cost differential, right? Because one of the putative advantages of not having an ICU stay is potential costs. And obviously that's balanced by cost of equipment and other kinds of things. But I just would highlight that they've published a piece looking at that, and I just would commend them for sort of taking on that as an important additional analysis. And obviously the costs are fluid over time, and there may be ways to kind of optimize both sides of this, and just appreciate Wissam's efforts in trying to help understand those kinds of implications as well.
I just want to thank everyone for the great discussion, and thank you, Dr. Jabber, for joining us even when traveling. And this is a really awesome trial and a great step for Emory. So thank you.
Thanks everyone for coming today. We'll wrap it up since we're at the top of the hour, and we'll see you next week. Thanks.
The preceding program is copyrighted by Emory University.